when the anion get corrected. Is that clear, folks? Unless that you do that, you won't know whether you cured the problem or not. The patient subsequently developed worsening acidosis requiring intubation for respiratory. You'll see one small mistake, what happened, right? Now, in here, what is the key here, right? They have more options. Deficiency of knowledge. No, they are doctors, so we don't pick that. We pass step 1 and step 2, so knowledge is good. Okay. Now, excessive patient caseload, that doesn't matter. Inadequate patient handoff, no, they did everything properly. Judgment error, there's nothing about judgment. It brings you to E and F. See, that's the main reason I wanted to do this question. What is the difference between physician burnout and physician fatigue? What's the difference? Discuss with me, folks.
Is the difference fatigue is just they're tired? For burnout is not that they're just tired. They have like
just use the both word in there, burnout and fatigue.
Burnout is not being tired, but having also like a negative attitude about their job, right?
Okay. No, I could see where you're going. So physician burnout is something to do with emotional. So basically the best example, I'll tell you myself. I live in suburbs. I used to work in downtown Mount Sinai. I used to drive 3 hours a day, 7 days a week for almost 9 years. Okay. I spent 3 hours on transport and 7 days a week and 9 years. So after a while, I used to tell my people that I feel burned out practicing medicine. It is not that I don't get 8 hours sleep, I still get. But when you do things again and again, and you are actually losing interest of it. Okay, so you feel burnout doing the same thing mentally. It is a mental burnout. That's what I keep it, not physical. Does that make sense, folks? That's the burnout. Physician burnout mean it's a mental issue, whereas physician fatigue, it's a physical issue that they didn't get enough sleep, they are not doing. So here, this physician did a nighttime moonlighting. So the answer is fatigue. He didn't get enough sleep. Okay, so always write it down first. Physician fatigue is physical, physician burnout is mental. Is everybody clear, folks? That is a simple, easy way to keep it. Okay, it's about emotional, right? Burnout, that's all it is. A lot of physicians quit practicing medicine after COVID. Is that the fatigue or burnout? It's a burnout. Psychologically, they didn't want to do it anymore. So burnout, psychological feeling, fatigue is physical, right? So simple and easy, folks. So here the problem went wrong. The patient was late and not getting enough sleep and stuff. That's the fatigue. Is everybody clear? All right. That's the key. Okay. Now you could see, let's see where the E talk about. See, physician burnout refers to a state of emotional exhaustion and stuff, folks. Okay, so that's the idea here. That's nothing to do with fatigue. Like I was talking last night, one of the SGU student is doing residency now, okay? He's in 3rd year of residency. He called me because they need to select their fellowship. When he was a student with me, he used to say he loves critical care pulmonology. Okay. Now, when he was talking to me yesterday, he said he changed his mind. He want to go into rheumatology. I asked him, why do you want to go into rheumatology? He works for military hospital in Texas. Okay. Now, his explanation, Dr. Roy, in military hospital, I am tired of doing this much, and pulmonary and critical care is so much work. And mentally, I am tired. That's why I want to go into easy work, which is your rheumatology. So I literally asked him, so you mean you have a physician burnout? He started laughing, right? So it is a burnout because you feel that mentally you don't want to do that anymore. Does that make sense, folks? See, that's why I tell whenever you want to do a fellowship, you don't make that decision now. In medical school, you want to do everything, right? You want to be a cardiologist, you want to do this, everything. The reality changes when you come to a 3rd year of medicine. Same thing with residency too. People say different things. I want to be a surgeon. Well, you have to wake up at 3 o'clock in the morning for the rest of your life. Surgeons wakes up at 3 to 4 in the morning, guys, because you need to be at the hospital at 5 o'clock. Because the grand round starts at 5:30 to 6. So usually they leave at 3:30, go to the hospital, They go through all the patient information list and stuff, then you start. Can everybody do it? No. You know how many surgical residents quit after first year? So many of them, folks, you don't find out those things. They switch it because not everybody can keep it, right? So that's physician burnout. That's a psychological and versus fatigue. Is that clear, folks? All right. That's that. Let's do one more here. Now here, can you discuss this or no? You cannot. Okay. So you cannot discuss. They're asking, are you treating, which of the following is the most appropriate response by gastroenterologist? Even though in the hospital, what do we do when they ask, when my friend asks? I open my iPad and give that patient information, go through it. I mean, that's a reality, folks. You discuss everything. Okay. That's the truth. You can't deny that. Why we give the iPad? Because I don't want to repeat everything. You check it, right? That's reality. But technically, you are not supposed to do that. But the reason we do it, thinking they keep it, in, he won't disclose to anybody. So here the answer should be, I cannot say whether or not he is my patient. Okay, they cannot disclose anything, folks. Okay, that's the answer. All right, let's do this specific question for me. All right. What did we talk about this morning about if you don't believe in abortion? You refer the patient to a different one, right? So what's the answer? Refer the patient to another provider who performs abortion. Clear, folks? Okay, so here, which of the following is the most appropriate course of action? We have to refer the patient, right? That's the idea here, folks. Any question in here? No? Okay, that's that. Let's do next one. Okay. A frail 93-year-old woman with a mild dementia enters a nursing home due to difficulty managing on her own. She has recently had several falls, including one during the night while getting out of the bed to use the bathroom. Okay. The patient attributes this fail to clumsiness. Syncope walk-up is unremarkable for any other abnormalities. She has a medical history of hypertension, osteoarthritis, depression, and anxiety, many conditions. Her medication include amlodipine, sertraline, all these things, folks. Which of the following is the most effective strategy for decreasing the risk? What can you do to decrease the risk of falling? Now, some student picks bed rails. If bed rails is right, cane is also right. If cane is right, then the walker is also right. Is that clear, folks? But the question is here, what can you do to help you? You need to find out what causing the clumsiness, what something is causing her. Always find out why first before you give a solution. Is that clear, folks? Here should be medication review first. You need to do a medication review to see any of these medication causes anxiety and then anxious or anything like that. So medication review. The answer of cane and walker, that could help, but doesn't mean they won't fall even if they have a cane or walker. Does that make sense, folks? Right? Amitriptyline causes dizziness. Exactly. Some medication causes dizziness. So if you know that medication causes dizziness, no matter how much help you give walker, they will fall. Is that clear, folks? So always find out what causing before you give a solution. Okay, see in here, finding what medication is causing the problem is actually treating the problem. Giving walker and bed rails are called symptomatic treatment. You know, there are two ways you could treat a patient. One, you treat the problem, underlying problem, or one, you just treat the symptoms. Which one is the best? Always finding out what causing the problem. Is that clear, folks? That way you could completely cure than just treating symptomatic, folks. Okay, so that's that. That's the idea, folks. Okay. All right. Now there was something I saw here. We did that. Not this one. We did that. This one. Yeah. So some people picked A. Communication should be verified by asking the patient to describe what she understood. What they are trying to do is teach back method. But how can they explain the teach back method if you are not clear about language? How do you know the teach back method itself is right? No. The answer should be here. The surgeon, what he did is wrong because of 3 weeks course. You cannot talk. Okay. So the surgeon's actions are inappropriate as they potentially violate the rights of the patient. You need to bring somebody who speaks fluent English, Spanish at that point. Is that clear, folks? So that's the key here. Okay. E is the option. That's the answer here. Is everybody clear, folks? All right. Now, you see, in the beginning, You guys were making mistakes, but as we do question, you guys started getting right. When it comes to this is not a theory, right? This is a situational question. When you do question, you started learning, okay, this is how you think. The only way to do that now your homework